I will go ahead and start the next lecture, guys. I'm Jason Rollins. I work at Princeton. We're going to talk about pulmonary edema today. And I hope y'all can see. There's a lot of chest x-rays. I hope they project pretty well. It's going to be hard for me to see from down here. It's hard to get chest x-rays to project well on the screen anyway. Just trust me on some of the quality of what I'm telling you about it. Okay, pulmonary edema. This is the worst slide in the whole talk, so don't let this one scare you off. There's a lot of the numbers here. I'll try to break it down into something that's easy to understand. So pulmonary edema. So there's the Starling relationship describes flow across a membrane, and we're talking about flow from the blood vessels into the interstitial space. So net filtration is this KFX, which is the filtration coefficient, times PC minus PI, times PC minus PI minus this coefficient, and then OC, okay, so lots of words there. So basically what that means is this PCPI is the capillary pressure versus, or minus the interstitial pressure. And the capillary pressure is higher because it's a blood vessel and it's under pressure there. And then the interstitial pressure is on the other side of it. Oncotic pressure is minus this coefficient times oncotic pressure. Oncotic pressure is the opposite of that. The oncotic pressure is trying to keep fluid in the capillaries and not allow it to seep out into the interstitium. So those are the kind of the opposite of each other. So net filtration is this filtration coefficient times the change in hydrostatic pressure minus the change in oncotic pressure. So the higher the pressure inside the capillary, the more it pushes fluid out into the interstitium and causes pulmonary edema. The higher the oncotic pressure, basically meaning the more protein you have in your blood vessels, the more that tends to keep fluid there and not let it seep out. That's why when you get some sort of an albumin deficiency, you're more likely to get edema everywhere because there's not as much oncotic pressure. So there's that. So what does pulmonary edema look like? There's a lot of different manifestations of this. The most common is cardiomegaly. We'll talk about that more specifically in a while. Cardiomegaly with perihilar infiltrates, cephalization, and small bilateral pleural effusions. We'll look at all those things in detail. But that's a pretty good pulmonary edema chest x-ray there. But that's not specific for pulmonary edema at all. There's a lot of other things that can look exactly like that and aren't pulmonary edema. That's why it's hard to sort out sometimes. But that's your classic pulmonary edema chest x-ray. One of many classic examples. Another classic example is this bat wing pulmonary edema. You hear this expression sometimes. A lot of times like rapid onset pulmonary edema where you didn't have it and then you do, it gives you this bat wing appearance. So what does that mean exactly? It's perihilar infiltrates. Here you have the cardiomegaly is not as pronounced. You don't have pleural effusions. You don't have pleural effusion on that side anyway at all. But you do have infiltrates that start at the beginning and spread out from there. Sort of like bat wings, I guess. I don't know what that means exactly. There's all different kinds of bat wings. Even the bat symbol has been through a lot of different incarnations. I think this one is the one I like the best, the second from the left on the bottom, which is the Batman and Superman versus Alien and Predator, which is never a movie or a comic book I read, but I think that was the closest to me anyway. So that's batwing pulmonary edema. Interestingly, there's a disease called chronic eosinophilic pneumonia, which is reverse pulmonary edema. It's the opposite of that, where you have the infiltrates around the edges and central clearings. Anyway, this is your classic pulmonary edema. Curly lines. These are not going to show up. There's another slide where it blows up a little bit more. So another thing you see on imaging is these curly lines. You hear about curly bee lines all the time, but the curly lines there's a bunch of different kinds. So it's basically prominent interlobular septa. So the septa separating the lobules get thick, and then you can see them better than usual. What causes that? Probably edema, pulmonary edema, or just lymphatic engorgement of the connective tissue septa. Usually occurs when you have high wedge pressures, high capillary pressure, which is usually caused by a heart problem typically. Usually when your wedge pressures get 20 or 25 or so, you can start to see some of these. So here we go. So there's curly bee lines. Those are the ones you hear about all the time. Curly bee lines are these on the outside. They're 1 to 2 centimeter lines, perpendicular more or less to the pleural surface and peripheral here. So these blue arrows are the curly bee lines. Curly A lines are perihilar. These are the ones kind of close to the hilum. So these orange lines are the curly A lines. I know you'll never be able to see those. You'll never see them on an actual chest x-ray. That's even hard to see here in my perfect example. Curly C lines are peripheral but don't quite reach the pleura. They don't contact the hilum. They don't contact the pleura. These are curly C lines. So orange, blue, green is A, B, C, which is not, you'd think it would start A, B, and C, and then the C lines would be on the outside edge. But just to complicate things, they didn't do it that way. They went A, B, C. So there you go. Cephalization, I mentioned that earlier. What's that? This is the cephalad direction is up, right? So basically, normal pulmonary venous structures are more prominent at the lung basis. That's just gravity. If you look at a chest x-ray, it's usually a little bit whiter at the bottom than it is at the top. And one of the reasons for that is just because there's more blood flow at the bottom of the lungs than the top. It's just gravity. So if I stand on my head and you do my chest x-ray, I'm going to have cephalization because now there's more blood flow at the top just from gravity. So if a person's not standing on their head and they have cephalization, that's a problem. What causes that engorgement of the pulmonary venous structures due to heart failure? Usually, and you get this great expression that I love to put it in quotes, anti-gravitational redistribution, which sounds awesome. It basically just means that there's more blood flow. It still respects gravity, but not in the way that you would normally think of it, just because of the high pressure. It pushes it up rather than down. So here's a pretty good picture of cephalization. I think you can actually see it pretty good over here. This is where the yellow line, the top right yellow lines are. This is kind of blown up here. So normally the blood vessels are more prominent down here. Now you can kind of see them thick and large and extending upwards where these yellow arrows are. So that's cephalization. That's another classic pulmonary edema finding. So cardiomegaly, mentioned that earlier. That's just a big heart, right, or a big heart shadow. Anyway, that's not necessarily the same thing. Big cardiac silhouette. Normal ratio of the cardiac silhouette to the thorax shouldn't exceed 0.5. You can usually just take your pinky and your your pinky and your thumb, measure the heart, move it to the midline, and if it extends beyond the chest, the edge of the chest, then that's more than 0.5. So, and that's when you're doing a PA film, so your standard PA lateral chest x-ray. You kind of have to use caution if you're looking at portable films, just the way the x-ray is shot, it makes the heart look bigger than it normally would on a film where you're shooting from the back forwards. Also, a large cardiac silhouette doesn't necessarily mean cardiomegaly. There's a bunch of different things that can do that. If you don't inspire well, then the diaphragm's kind of pushed up and sort of pushes the heart up. It makes it look a little bit bigger. A pericardial effusion is not cardiomegaly. It's just a big cardiac silhouette because there's the bag around the heart is causing a lot of that whiteness. You know, there's pericardial fat pads sometimes, which is easier to see on CT scan, easier to identify on CT scan than chest x-ray. Okay, well anyway, there's the point I was just making about cardiomegaly. This is a normal cardiac silhouette here. That's cardiomegaly. So that's, if you do the thumb pinky thing, it does not extend on the left side, does not extend out past the edge of the chest. And it clearly would on the other side. Okay, this is impossible to see. I don't know, I can actually see it pretty good. Peribronchial cuffing. So this is another x-ray finding of pulmonary edema. It's just haziness around the bronchus. Bronchial wall thickening can do that. So if you have bronchitis, for example, you can get peribronchial cuffing sometimes. Or lymphatic congestion, which is what we're talking about due to fluid. Bronchitis or pulmonary edema. This one's better up here at the top, I think. You can kind of see there's a black spot with a little white circle around it. That's peribronchial cuffing. Another, again, finding of pulmonary edema on chest x-ray. Pleural effusions are commonly associated with pulmonary edema, usually bilateral. If they're unilateral, they're almost, I won't say almost always, but the great majority of the time they're just on the right. If they are bilateral, they're usually a little bit worse on the right, usually. What causes that? Lots of words, basically. Basically, there's fluid present in the blood vessels, and the lung lymphatics can't soak it all up, and so they look for a place to go, and the fluid gets into the interstitial space, and then it's sort of not accessible to the lung lymphatics anymore. It can't clear it, and it flows down this pressure gradient. There's negative, when you breathe in, that creates negative pressure, so your pleural space is close to neutral or slightly negative. It's definitely not positive when you're breathing in anyway. It flows down the pressure gradients and gets into that space, and then it's not accessible to anything except for the thoracentesis catheter. Or if you diurese people a lot, sometimes it'll improve the pressure enough that it'll soak back in. Okay, pleural effusions. These are pleural effusions here. This is not a classic, or not the best pleural effusion chest x-ray. But basically that nice sharp angle that we saw earlier when I said this person doesn't have a pleural effusion, there's a nice sharp black angle here, the costophrenic angle. That's not there anymore. Now it's white, and then there's a little bit of a meniscus there, not a great one, but a little bit of meniscus. You can see the meniscus better on this decubitus film, where this person's lying on their right side, and then the effusion kind of layers out. You see a nice white meniscus there. That's a pretty good size effusion there. That's probably a liter, maybe, just guessing. That's a decubitus film, or the Epic computer system calls it the Bucky film, which is usually the easier way to order it. CT scan of some pleural effusions. This is a little bit of pulmonary edema here on this image on the right on the lung windows. It's just kind of fuzzy, and you can see with a lot of different things, but here it's probably pulmonary edema because the person also has bilateral pleural effusion slightly greater on the right than the left. That one's moderate to large there, and this one's smallish over on the left side. When I say left side, I mean the right side of the CT scan. That's how you read CTs. Left is right and right's left. Okay, cardiogenic pulmonary edema is by far the most common cause of that. How do you check that? You can get the Swan-Ganz catheter, and you can, or it's also called a right heart cath. Wedge pressure for pulmonary edema is usually greater than 18. So what does wedge pressure even do? Here's how the Swan works, basically. You start over here somewhere in the venous system. You blow up this balloon, which helps, then the blood flow can float it out where you want it to go. And you enter the right atrium, either looking at EKGs or looking at the fluoro C-arm, where you can kind of get a real-time estimate of where you are. And looking at the pressure tracing too. Now you look at EKGs because when you start to get some PVCs, you know you're in the right ventricle and you need to get going real fast because you're causing some arrhythmia problems. But basically, you just look at the pressure tracing or fluoro. So you start here, you come out here, you come to the right atrium, go through the right ventricle, you go through the pulmonary artery, and then the balloon finally wedges in these pulmonary capillaries. So you're measuring the pressure at the tip, and then the balloon just kind of keeps it stuck there. And it's stuck there, and it prevents more blood flow from coming in. So once you've got a good seal, what you're measuring at the tip is the backflow, the pressure on the other side of that. Now you're measuring left atrial pressure, and you're measuring LV pressure, which goes back up here and hits that. So what you're actually measuring or what you're estimating, what you think in your mind when you get a pulmonary capillary wedge pressure is, what I'm measuring is your LV EDP, the left ventricular end diastolic pressure. So basically, what's the filling pressure of the left side of the heart. It's an estimate. There's a lot of stuff that can mess that up. If you have like mitral valve stenosis, for example, what you want to have is one continuous free-flowing column of fluid separating the end of the pulmonary catheter, or the Swan-Ganz catheter, and the LV. And if there's like a valve blockage or something like here at this mitral valve, then that's going to mess that up. It'll mess your pressures up. So cardiogenic pulmonary edema, the rate of fluid accumulation in your lungs and then sometimes around the lungs is just basically related to the ability of the lung lymphatics to remove it. And if you get more fluid going in and they can't remove it fast enough, then that shows up as shortness of breath and chest x-ray problems and pulmonary edema. An acute rise in wedge pressure can have edema with as low as 18. So if all of a sudden I had flash pulmonary edema, the pressure went from 10, whatever it is now, to 18, now I've got flash pulmonary edema, right? So what are the causes of flash pulmonary edema? What are the causes of an acute rise in LV-EDP and wedge pressure and then acute pulmonary edema? Hypertensive urgency can do it. Say I did a bunch of cocaine and my blood pressure went from normal to super high all at once, and my heart wasn't ready for that. So that high LV-EDP, high wedge pressure, and pulmonary edema. Acute ischemia, if your heart is normally beats well and then all of a sudden it's not getting blood flow and it can't beat well anymore, and now it's stiff and thick. That'll do it. Severe tachyarrhythmias, this is a diastole issue. Your heart has to be able to fill up so it can squeeze out all the blood. And if it's beating so fast that there's not enough time for diastole to do what it's supposed to do, to fill up the heart, then you've got a problem, and fluid backs up because it's not filling up fast enough to squeeze it out efficiently. And acute valvular disease, say if you had an MI a week ago and the mitral valve we talked about, say you have had an MI a week ago and all of a sudden you blow a chordae tendineae, the little things that connect the mitral valve to the rest of the heart. And now you've got wide open mitral regurgitation, and when the heart squeezes, instead of the blood going that way out into the body, it goes back up. That's obviously going to increase the pressure and give you pulmonary edema. Chronic CHF might actually allow higher pressures, so if you're just kind of sort of used to your heart not working well, sometimes people with chronic like diastolic heart failure will run wedge pressures much higher than that. Maybe their pressure's 20 or 22, and they're not really all that wet. Again, this this is an estimate. This is actually a good point. So we're talking about pressure, and when I'm saying pressure, but pulmonary edema is a volume problem, right? So pressure and volume aren't the same thing. You're just kind of making a mental conversion in your head of pressure's high, and that equals you're wet. But that's not necessarily the same thing. So you have to use a little clinical correlation sometime to think about the kind of the acuity of the situation. I sort of talked about this already. So your body is, now you're short of breath, and your body's trying to fix that. You're hypoxic, you're short of breath, and you're trying to compensate for that. You compensate for it by your heart beating faster, and again, that can be kind of counterproductive. You're freaking out because you can't breathe and you're hypoxic, and that increases your catecholamines, adrenaline, and that increases your systemic vascular resistance. So now there's afterload. Afterload is what your heart is pushing against to try to get the blood to go the correct way and not back up this way into your lungs. So the tighter your blood vessels are squeezed down, the harder it has to work, and increased cardiac O2 demand too. All right, so systolic dysfunction, that's I don't know if it's the most common, but it's the easiest to understand reason to have cardiogenic pulmonary edema. Your heart's just not squeezing enough. It should squeeze at ejection fraction, squeeze out 55% of the blood that's in there, and it's only doing 30. That's systolic dysfunction. What can cause that? Coronary artery disease, lung or scarring from chronic ischemia or an MI, sometimes just idiopathic, toxins, anthracyclines, doxorubicin, which is a chemo drugs, the classic cause of drug-induced systolic heart failure, viral myocarditis, and postpartum cardiomyopathy sometimes. And all this can sometimes lead to poor flow to the kidneys. So because your heart's not beating well, there's poor flow down to the kidneys. And the kidneys say, what's happening? The kidney doesn't know what's going on with your heart. The kidney only thinks about things in terms of itself. And all it knows is it's not getting good flow, and it thinks it's not getting good enough flow because you're too dry. And need more fluid, and you need more salt, and you need more stuff in the blood vessels. So then the kidneys send out hormones to induce salt and fluid retention, which again is counterproductive. Because now your overloaded heart is even more overloaded because it's got more fluid on it. Okay, so acute cardiogenic pulmonary edema, how would you treat that? Treat it as if I treat cardiogenic shock. You can use dobutamine. Dobutamine is a pure beta agonist. It's a beta 1, beta 2 agonist. So beta 1 makes your heart beat harder, faster, stronger. Stronger is the key point that we want to say we're focusing on there. And it's a beta 2 agonist. So remember, albuterol is a beta blocker. It's a beta 2 blocker. So when you block beta 2 agonist, you relax smooth muscle. Is that right? Yes, yeah. Albuterol is a beta 2 agonist. I got very confused for a second. Albuterol is a beta 2 agonist, and so is dobutamine. It's a pure beta agonist. It improves beta 1 and beta 2 function. Anytime you stimulate beta 2 receptors, you relax smooth muscle. So if you're a pregnant woman having premature labor, and you get some terbutaline, your uterus relaxes. If you're having an asthma attack and bronchospasm, you get the beta 2 activation, then your airways relax. If your SVR is too high and your heart's struggling to push against that high pressure, you relax activate the beta 2 receptors, relax the smooth muscle. Afterload goes down, heart's got an easier job pushing blood where it's supposed to be and not back up into your heart. Milrinone is another thing, too. That's a phosphodiesterase inhibitor, which basically does the same thing, just through a slightly different mechanism. Let's see. Let's get beta blockers in this for a second and talk about my favorite drug, spironolactone. I'm not even kidding. This is my favorite drug. I love spironolactone. It's an aldosterone antagonist. If you have chronic systolic heart failure, ejection fraction less than 35%, and class 4 heart failure, spironolactone reduces mortality 30% versus placebo over a 2-year period, which is fantastic. I think spironolactone is dramatically or significantly underutilized. I wish it had a lobby. I kind of wish it was not a generic agent, so there were drug reps pushing it and saying, hey, this is great, you should use spironolactone. Because we kind of forget about it a lot of times because it's old and I guess it doesn't have a lobby. But it's a great drug, like fantastic mortality improvement. And how does it work? It raises potassium a little bit. Most diuretics drop your potassium. Spironolactone raises your potassium. And one thing that increases your risk for, potassium can't get too high, obviously, but if it's low, that increases your risk for ventricular arrhythmias. And this goes the other way and helps to reduce that a little bit. It may directly protect the heart just through reducing fibrosis and LVH, and also blocks this renin-angiotensin system. So your kidneys are overactivated, and this kind of helps to blunt that some and probably improves the effectiveness of ACE inhibitors. Okay, all right, how do you treat pulmonary edema? Lasix, usually, or just any, doesn't have to be Lasix, but any kind of loop diuretics, Lasix or Bumex. You can just push that, or you can hook it up as a drip. This dose trial compared IV Lasix versus IV push Lasix, like 40 BID or 80 BID versus a continuous drip. No significant difference in this study in renal function or significant outcomes. Initially, when you push Lasix, one disadvantage you get is sometimes you get a little hypotensive. One advantage is you get a little bit of venodilation, just sort of like morphine or any other opiate would. So if the heart has a lot of pressure behind it, fluid backed up behind it, and you relax those vessels behind it, that reduces some of the load on it. So that can be helpful. Lasix bioavailability is about 50%. So when you take a Lasix pill versus get a Lasix shot, it's the ability or the amount of it that makes it into your bloodstream is about 50% or so. But varies a lot depending on a lot of things. Some of the things that I think it varies on is gut edema. So if you have bad anasarcose and your gut is sort of swollen and maybe it doesn't absorb as well. So bioavailability varies from 10 to 100%, which is, well, I don't even know why I even put that 50% up in there. The confidence intervals are not great there. There's another drug, torsemide, which is another loop diuretic Demodex. It might be a little bit more predictable. That's what they taught me in med school anyway. Its oral bioavailability might be a little easier to count on. Diuretics, thiazide diuretics, Dimox, we'll talk about that in a little bit. Fluid restriction, you're too wet, so you need to get less wet, so don't drink as much. And definitely don't eat as much salt. Other treatment for that, vasodilators like nitrates. Again, this is a venodilator. So if the heart's stressed out and if you reduce some of the workload on it by reducing the pressure on the backside, that can be helpful. You can get tachyphylaxis. Tachyphylaxis means your body gets used to it and then it doesn't work anymore to nitrates, and that can occur within a few hours. So don't consider that a long-term solution. There's a bunch of different things you can use for hypertensive urgency. Nitroprusside would just be one example. So this is an afterload problem. Your blood pressure is so high, the it's trying to squeeze the blood out, but it can't because the pressure is too high and it's going back up this way into your lungs where it shouldn't be. So nitroprusside, just classically you don't want to use that with renal problems, and if you do, you got to go really, really short on the timing there because it's metabolized to cyanide. A day or two tops with the nitroprusside. Okay, diastolic dysfunction. What's diastolic dysfunction? Systolic dysfunction is easier to understand because your heart just doesn't squeeze well. Diastolic dysfunction is when your heart doesn't relax well. A lot of times it's thick, it doesn't relax, and it can't fill up totally. With systolic dysfunction, it's full, it just can't squeeze well. This one, it doesn't fill as good as it should. It doesn't relax well. And so all these like ACE inhibitors and beta blockers and aldactone and all that stuff that's good for, I skipped over a couple of those, that's good for systolic dysfunction, maybe diastolic dysfunction, but they're definitely not as well studied. The main thing there is you just want to keep your heart rate under control. You want to keep the afterload low. That afterload means blood pressure here. Calcium channel blockers maybe, which might directly relax the heart. Digoxin, no. Digoxin is a drug that makes your heart, it's good, pretty decent anyway for systolic dysfunction. And wouldn't really work for this. You have to kind of be cautious with diuretics or nitrates on this one. Because if you get too dry, then this heart, which is thick, it's thick and the space is already small inside it. And if you get too dry, now it's a really small space, and you can accentuate some obstruction. Now when it pumps, it's sort of obstructing on itself because there's not enough in it to keep it open. So you got to be a little bit more cautious with diuretics with diastolic dysfunction and systolic. Okay, non-cardiogenic pulmonary edema. So we talked a lot about your heart because that's the easiest thing to think about, and it's the thing you're going to see most of the time. But there's a bunch of causes of non-cardiogenic pulmonary edema, also known as permeability pulmonary edema. So here your wedge pressure's okay. You just have damage to or leak from the alveolar basement membrane, and fluids leaking out directly. What can cause that? ARDS a lot of time. ARDS a totally separate problem where you just have lots of lung inflammation. But it also damages the capillaries, and you can get edema leaking out there. The interstitial protein concentration is usually greater than 60% there, and it's usually less than 45% with cardiogenic pulmonary edema. That basically tells you that the protein which is in the capillaries is not where it's supposed to be anymore. It's leaked out because of a damage to the membrane. It's leaked out into the interstitium and is now dragging fluid along behind it. Okay, so there's that. Non-cardiogenic pulmonary edema, uncommonly due to malnutrition, hypoalbuminemia, anasarca. Supposedly, this is what UpToDate says. I don't know. I feel like I see this all the time, where people just have terrible liver disease, or they never eat anything, and their albumin is 1.6, where it should be above 4. I feel like I see this a lot, but supposedly you don't get actual pulmonary edema, not really severe pulmonary edema anyway, commonly. Just due to that, if you don't have any other problem. High altitude pulmonary edema. This is a fun one to talk about, or HAPE, high altitude pulmonary edema. It's another one of these non-cardiogenic pulmonary edemas. It's just a capillary leak syndrome. The BNP, or it's called the brain natriuretic peptide, but it's a hormone released by your heart in the setting of excessive volume, usually excessive stretch, and it makes you urinate out some of the extra fluid. And that's almost always high in classic heart failure, and it's typically normal here. Why do you get high altitude pulmonary edema? It's caused by hypobaric, low pressure hypoxia, low oxygen. Basically, you get pulmonary vasoconstriction, or acute PAH. It's irregular and it's sort of uneven. All your blood vessels dilate in the setting of hypoxia, with the exception of your pulmonary vessels, the vessels that connect your heart and your lungs, coming from the right side to the lungs, constrict in the setting of hypoxia. All the others dilate, and these constrict. So you go to altitude where there's less oxygen and less pressure driving the oxygen in. And those vessels constrict, especially at night when you're asleep. They don't do it uniformly, kind of irregularly, but that's increased, and that increases the capillary pressure, and it tends to squeeze fluid out. Right? Increased sympathetic tone. There's a bunch of different reasons you could have this. Inadequate nitric oxide production. This is the thing that the PDE5 inhibitors help improve usually. Overproduction of endothelin. That's the thing that endothelin receptor antagonists, all these are PAH drugs, help with usually. Anyway, but just remember the hypoxia thing. That's easiest to think about. So pulmonary edema usually occurs above 2,500 meters. That's about 800 feet. The incidence at 5,500 feet, it seems like a random number, but that's something I saw, was somewhere between 2 and 15%. Just to give you some examples of what these numbers are, Mount Kilimanjaro, the tallest mountain in Africa, is 5,900 meters. Mount Everest is about 8,800. The rate of ascent is a key factor there. If you're going to Mount Everest, you better not just take a plane and start at the top. You're gonna get it for sure. You have to go slowly. You have to go very, very slowly to the top to help prevent this. HAPE is more common in men. It's more common in cold temperatures, which you're climbing a mountain. Pre-existing infection, that can do it. Really, really strenuous exercise. Again, you're climbing a mountain, so a lot of these things are kind of intuitive. You can get altitude pulmonary edema at less than 2,500 meters if you have pre-existing risk factors for PAH. So if you have PAH, you probably shouldn't go to Peru or something. And just a few other numbers. Cuzco, Peru is about 3,300. Mount Olympus, the one in Greece, is about 2,900 meters. The one in Birmingham here is about 200 meters, just above sea level, if you're curious. Mexico City is about 2,200, and Denver is about 1,600, which is almost exactly a mile high. So remember Mexico City for later. Altitude pulmonary edema, people live there. They don't live on Mount Everest, but they live at the top of some of these mountains or near the top. And so it's very rare to get this, and it's because they're chronically acclimated to that. At sea level, your partial pressure of oxygen is about 760. It's 747 in Birmingham, incidentally. Partial pressure of, so 740, or barometric pressure, sorry, not partial pressure of oxygen. The barometric pressure is 760 at sea level, and it's 747 which is an easy number to remember here in Birmingham. Average partial pressure of oxygen in the air is about 150 at sea level. Is that right? Yeah, and that makes for a PaO2 in your blood of 100 and a CO2 of about 40. In Denver, the partial pressure of oxygen is about 630. That's significantly lower. It's still about 21% oxygen, though. 21% oxygen here. It's about 21% in Denver. It actually doesn't change much there. If you get up to Everest, I think it's about 15, 16%. So it does get a little bit lower there. But mainly, there's pressure. The oxygen in Denver is about the same as far as the content in the air. There's just not as much pressure helping to drive it into your lungs when you breathe. So the average PaO2 is a little bit lower in Denver, 80 versus 100. Okay, but why do people who live not just at Denver but at higher altitudes, why is this rare for them to get? So this is your classic oxygen dissociation curve. The black line is normal here, the one in the center. So this is PaO2 on the bottom of the screen moving to the right, and this is oxygen sat over here on the left going up. So normally at say a 90% sat, your PaO2 is about 60, maybe just a little bit above normally. But some things move that curve to the right. So if you move the curve to the right, your hemoglobin's affinity for oxygen is lower. So basically, oxygen isn't doing you any good when it's glommed onto your hemoglobin. What the purpose of the blood is, the hemoglobin transports the oxygen out to your tissues and then lets it go. And only when it's let go can it get into the cells and do what it's supposed to be doing. So if you move the curve to the right, oxygen lets go easier and gets out into the tissues where it can do some good. It's not stuck on your hemoglobin. So things that move that curve to the right, imagine you had sepsis. Imagine you had a terrible infection and sepsis. So you have a high fever, that moves the curve to the right. Your pH, as you develop an acidosis, is lower. That moves the curve to the right. And that's good because you need oxygen when you're sepsis. Your tissues need oxygen. Your hemoglobin doesn't need it. Your tissues need oxygen, and it's released easier. The other thing here is this DPG, or 2,3-DPG, which is a molecule in your red cells that moves the curve to the right. And that's the thing that's high in residents of high altitude, that pushes or allows the oxygen to get off of the hemoglobin easier. Interestingly, that's the thing that's a little bit depleted in blood bank blood, if you ever get blood straight from the blood bank, as it's sat there in the freezer or in the cooler or whatever for a while, it tends to get relatively 2,3-DPG depleted. So blood bank blood tends to have the curve pushed to the left, which is not as good as what you want. It holds on to the oxygen. You don't get quite as much effective oxygen delivery as you want it. It builds up in a few hours, but right out of the tank, it's not quite as effective as you want it to be. Okay, high-altitude pulmonary edema, typical symptoms of that are just pulmonary edema, gradual onset of shortness of breath, pink, frothy sputum. That you see that with any kind of pulmonary edema. Sometimes hemoptysis. Symptoms usually begin 2 to 4 days after arrival. Again, you got to go kind of slow there. After you've been there for a week, it's pretty uncommon to get high-altitude pulmonary edema. Treatment for that, oxygen, obviously. Get down to a lower altitude, maybe hyperbaric therapy. One of your problems is hypobaric conditions, so hyperbaric therapy could be helpful. You see in the movies all the time, people are on the mountains and they have an acute problem and they get a shot of dexamethasone. It's always dexamethasone. I'm not sure why it's not any other steroid. Actually, that's not super effective, or it's not super well studied for high-altitude pulmonary edema. This is usually what you use for cerebral edema, which is another thing you can get up at altitude. Nifedipine, maybe, which is a calcium channel blocker. PDE5 inhibitors, which is the treatment for PAH. I'll come back to that on the next slide. The best thing to do here is just don't get it. So prevent that by going slow if you're going to the top of the mountain. Nifedipine, maybe. There was an actual study where they randomized 21 people. 10 patients in the nifedipine group, only 1 patient got high-altitude pulmonary edema versus 7 of 11 in the placebo group. So that kind of makes sense. Nifedipine is a calcium channel blocker. It prevents the blood vessels from squeezing too hard, and you don't get as much of that irregular PAH. PDE5 inhibitors, phosphodiesterase 5 inhibitors, that's like Revatio or sildenafil or Viagra. All those are the same thing. Adcirca, which is Cialis, it's another ED medicine. Those probably also help prevent that by preventing PAH, especially at night when you go to sleep. So next time you take a business trip to Mexico City and you take along a bottle of Viagra, good luck explaining to your wife that it's for your health. Yeah. Don't put health in air quotes. That's going to help you with your presentation. Also acetazolamide or Diamox. It makes sense that it would help with pulmonary edema because it reduces, it's a diuretic and it reduces fluid. But it's really more to prevent this acute mountain sickness, which is sort of a very, very light version of a lot of these things. Diamox works. Most diuretics make you urinate out acid, and then so you tend to retain bicarb. Diamox is the opposite of that. Diamox makes you urinate out bicarb, and you're left with more acid. So if you're, now you have a metabolic acidosis, and if you have a metabolic acidosis, then you breathe faster to compensate for that. You try to breathe out some extra CO2. And when you breathe faster, you're also bringing more oxygen in. And the more oxygen you bring in, then the less hypoxic you are. And the less hypoxic you are, the less tendency you're going to have to get these kind of hypoxia problems. You're basically tricking your brain into breathing faster, is essentially what Diamox is doing. Okay, neurogenic pulmonary edema. This is another one of these non-cardiogenic pulmonary edemas. Caused by a severe CNS event, subarachnoid hemorrhage, traumatic brain injury. Usually occurs within minutes to hours of the acute event, and really hard to confirm, really hard to rule out. Other illnesses, ARDS, for example, aspiration pneumonia. I've just had a major brain event and your brain's not telling you to swallow, so aspiration, either aspiration pneumonia, which tends to occur later. Usually don't get pneumonia within 24 hours. It takes a little while for the bacteria to set up an actual infection. You can get this thing called a Mendelssohn's pneumonitis, which is a chemical pneumonitis, basically. It's basically just aspirate gastric contents and all the acid flares up things. And within 24 hours, that's probably what it is if you aspirate. It's probably a chemical pneumonitis rather than actual pneumonia, which is going to happen later. But anyway, so you can see why it would be hard to sort out what the problem is when you have a white chest x-ray. After a CNS event. If it gets better like that, it was probably edema. Pneumonia doesn't get better like that. The Mendelssohn's thing can. So neurogenic pulmonary edema, the incidence with epilepsy, just to give you an example, is pretty rare. Overall, if you have a severe case of status epilepticus that leads to death, you have neurogenic pulmonary edema in about 1/3 of those cases. Traumatic brain injury, up to 20%. It's much more likely the more severe your injury is. Interestingly, you don't necessarily have to have increased intracerebral pressure. ICH, 1/3 of people with fatal intracranial hemorrhages, 1/3 will have neurogenic pulmonary edema present clinically. On autopsies, up to 71%. So this is really a lot more common than I think any of us think about typically. You just don't think about neurogenic pulmonary edema, but it's actually really common in the neuro ICU setting. What causes that? Damage to the medulla oblongata specifically, and basically is sympathetic nervous system overload. There's so much damage and your fight or flight system is going crazy, and there's all these hormones that are increasing afterload and causing damage to the lung system. You can prevent neurogenic pulmonary edema in animal models if you transect the sympathetic trunk. That's how you know this is a sympathetic problem. If you cut the trunk and then there's no sympathetic flow, it prevents the problem. Phentolamine might work too, which is an alpha blocker. You can also to go the other way, you can also give animals, if you're just feeling really mean that day, you can give an animal neurogenic pulmonary edema by stimulating the sympathetic trunk. Be nice to animals. So the mechanism for that, pulmonary vasoconstriction, obviously, it's sort of like the other stuff that we talked about. The more pulmonary vasoconstriction you get, increased capillary hydrostatic pressure, the pressure is just high in those blood vessels and it wants to go somewhere, so it squeezes out into the interstitium. Epinephrine can do this, these secondary mediators like histamines and bradykinins and such. Rapid increase in vascular pressure may cause microvascular injury, is what you call the blast theory. You were okay, and then all of a sudden acute insult, and now there's a lot of inflammation and damage. How do you treat that? Oxygen, plus or minus the ventilator, plus or minus BiPAP. BiPAP, incidentally, should be super helpful for a lot of these kinds of pulmonary edema. BiPAP reduces afterload a little bit. It helps to, it just helps. BiPAP is good. It should help, and it should buy you some time to fix some of these other problems. As your lungs get worse and there's poor gas exchange and you're not bringing as much oxygen in, you're probably also not getting CO2 out as effectively. Hypercarbia usually dilates the blood vessels that go to the brain. That can increase intracerebral pressure, which is bad. That's why you can hyperventilate people and reduce their intracerebral pressure acutely with a neuro event. That's not going to last all that long, and it's not going to be super helpful, but it is a thing that exists, and you might see on a test sometime. PEEP might be helpful. It might reduce cerebral venous. Well, PEEP can be helpful. It can be helpful for your lungs, but it might not help you so much here. As you increase your PEEP, there's more pressure in the chest. Maybe the venous return from the cerebrum headed down this way is not as good. That also increases intracerebral pressure. And that can be counterproductive. Medications, I don't know. There's not really any great studies on this. So basically just think about this as a thing that might be happening. Re-expansion pulmonary edema. This is another non-cardiogenic pulmonary edema. It can be fatal. I've seen this once in my life. It wasn't me, but I saw this happen to someone. Someone died from re-expansion pulmonary edema after a thoracentesis. It's more common with really large effusions. We'll talk about trapped lung a little bit on the next slide. So if you have a big effusion and your lung is smushed up and it's used to being smushed up, it's comfortable being smushed up. The patient's not comfortable, but the lung is. There's a surfactant problem. That's probably part of it. The lung's chronically atelectatic. The surfactant's not working as much, and then when it tries to go from smushed up to opened up in a short period of time, it just doesn't work. It doesn't work as well. Excessive negative pressure, you've sucked out a lot of fluid, you've created a lot of negative pressure there, and that can lead to capillary leak. That one kind of makes sense. You're just stretching stuff open and now it leaks a little bit. Reperfusion injury, that lung's not used to getting oxygen and now it's got a lot of oxygen to it, and that creates a lot of free radicals. These are just some examples of a trapped lung. This is your pleural pressure on the y-axis here, and this is the amount of fluid removed. The best ones to look at are these two on the left, the triangles and the circles here. So as the fluid comes out, you're starting with a slightly positive pleural pressure, slightly positive, and then it gets more negative, and then with just a little bit more fluid. I mean, we went from 600 to 800 here, with just a little bit more fluid removed. Our pleural pressure went from about 0 to negative 25 in this one, and it's pretty close here. So for all the reasons that we talked about, the lung doesn't like that. It doesn't like rapid changes in pleural pressure or pressure on it, stretching it open. How do you prevent that? There was a study where they did 185 thoracenteses and they stopped pulling. They stopped pulling either at the onset of chest pain or when the pleural pressure got to negative 20. So negative 20 would be right in the middle there on the y-axis. I've never seen a manometer to measure pleural pressure. I know they exist because they did the study here. I've never seen one. There's not one in a standard thoro kit. So usually what I do is when you start to get severe chest pain, say, that hurts a lot, doc. It's time to quit. Even if you know there's a lot more fluid, if they're telling you it hurts, just quit. And the same thing with cough. A little bit of cough is really common. You know, parts of the surfactant's messed up and parts of the lung are seeing the air, hadn't seen it in a while. So some cough is really common, but a really severe cough, quit. Don't keep pushing, even if you know there's still fluid there. So they stopped pulling there in this study. The average was about 1,600 cc's. The bags are about 2,000 cc's that come in the thoro kit. But the onset of chest pain or the change in pleural pressure ranged anywhere from 1,000 to 6,500 cc's in that study. So normally I just fill up a bag and quit. But you can keep going, and this study confirms, I think, that or suggests that it's safe to keep going if there's a lot more fluid, as long as you're not having either of those any significant symptoms or a significant change in pleural pressure, which is a guess because you don't know. You don't have a measuring device. Anyway, only one of the patients developed that edema in this study. It probably wasn't the 6,500 one. They would have mentioned that. Up to date actually suggests introducing air to reduce chest pain. So if you take off a lot of fluid and you have a lot of pain, you can't actually just put a little air back in there. And that, lung comes back down where it's happier. I've never done that. You have to be willing to accept a pneumothorax on your chest x-ray, and people look at you like you did something wrong afterwards. Normally I just stop when they get chest pain, and you don't keep pushing. But it's a reasonable thing to think about. So negative pressure pulmonary edema, I guess. Negative pressure pulmonary edema, strong inhalations against an upper airway obstruction, usually after a general anesthesia incident, somewhere between 1 and 1,000 and 1 and 2,000. Laryngospasm, say, you pull out the ET tube and then my vocal cords are spasmed up, and you have a massive increase in negative intrathoracic pressure. You want the air so bad, and you're trying to breathe in, but the vocal cords are spasmed up, say. And that's called the Mueller maneuver. Valsalva maneuver is when you bear down against a closed glottis. The Mueller maneuver is the opposite of that. It's inhaling against a closed glottis. So lots and lots and lots of negative pressure there, and that can give you pulmonary edema. Why does that happen? Well, the negative pressure in the chest increases venous return to the right heart. If you ever do this, if you ever sit in a quiet room and you feel your pulse and you breathe in, it actually speeds up a little. And if you breathe out, it actually slows down a little, your pulse does. Because when you breathe in, you create negative pressure in your chest that increases venous return. Now your heart's got to beat faster to get rid of that extra fluid. And it's the opposite when you breathe out, positive pressure in the chest. That disfavors venous return. Anyway, so all that negative pressure, capillary leak, capillary dilation, large sympathetic surge, which increases your afterload. Risk factors for negative pressure pulmonary edema: obesity, a short neck, obstructive sleep apnea, old ENT surgery, those sort of things. The things that you'd think would increase your risk of upper airway obstruction, but it just can't occur in anybody. Usually we're going to have stridor. With that, stridor's an inspiratory sound. That's stridor. And you might have this problem and then relieve the obstruction with racemic epi or with putting in an ET tube, say. And a lot of times the pulmonary edema develops right after that with pink frothy sputum and maybe frank hemoptysis, crackles on exam, the wet crackles on exam that you get. That's the physical exam sign of pulmonary edema. Again, it's usually immediate but can be delayed for a few hours. Treatment is supportive care usually. This is the last thing. Opiate overdose. You can get a non-cardiogenic pulmonary edema from opiate overdoses. Usually it's non-cardiogenic, so you might have a normal wedge pressure. The edema fluid protein concentration is equal to the plasma. So there's supposed to be a change in oncotic pressure. It's supposed to be a lot more protein in your blood vessels than in the interstitial space. And with this, there's not. They're actually pretty equal. And it suggests your capillaries just opened up and leaked and let all the, not like a pressure leak through a gradient, just opened up, and then there goes the fluid. Mechanism of that is unknown. Possibilities include direct drug toxicity and maybe just hypoxia. Treatment is Narcan. That's Ewan McGregor from Trainspotting. The treatment for this is supportive care plus or minus the ventilator. Usually gets better pretty fast. Narcan can help, and the prevention is the key. Just say no. Just choose life. That's all I got. Any questions? All right, guys. Thanks a lot.